Welcome to AETCM, the emergency medicine channel. Today, we are going to discuss a case about an 18-year-old female who was brought to our ER with complaints of generalized tiredness associated with bilateral pedal edema since about past 2 months. Shall we begin, sir? So, this was a small 18-year-old child who came to our ER with complaints of generalized weakness since about 2 months associated with pedal edema, and she was also complaining of dyspnea on exertion and also numbness over the upper and lower limbs. So on initial evaluation, the patient was conscious oriented, and in airway was talking also, and airway was appearing normal, patent and no secretions were noted. C-swine was also normal. In breathing but air entry was bilaterally equal, respiratory rate of 22 per minute and saturation of 96% maintained in room air. Circulation BP of 100 over 50 mmHg with pulse rate of 125 per minute. So we secured a cannula at that point of time, and at that point of time itself we did a routine blood investigation, reports awaited, and disability wise GCS was full, and pupils were bilaterally equally reacting, and exposure temperature was affable at that point of time, and other than that. We went in with our adjuncts to the survey. We did an ECG. ECG was showing sinus tachycardia with heart rate of 118 per minute. 118. So coming to the secondary survey, so she was a 18-year-old child with no known comorbidities, coming with the complaints of like generalized weakness for about 2 months associated with pedal edema, then complaining of numbness over the both lower and upper limbs, then yellowish discoloration of urine, excess bleeding PV, then passage of clots, and she was also complaining of weight loss about 5 kg in the last 2 to 3 months, then history of oral ulcers and diffuse hair loss. And she is a non-vegetarian and takes vegetarian diets from the age of 12 years. She was taking vegetarian diets. There was no history of any arthralgia, photosensitivity, skin rashes, any Raynaud's phenomenon, no any family history of any autoimmune disease. And then coming to the further knowing, she was not on any medications, but she was complaining of like bleeding PR also. So other than that was she was giving history of long duration. She was having bleeding PR, but there was no history of any hematemesis or hemoptysis. Then there was no allergic history, and last meal was about 4 hours back to our before coming to our ER. That was the main history from the child. So we went in with our routine investigation, sir. The investigation showed that she was having a low HB of 2.5.
Okay, 2.5.
2.5. And total count of 2.03 and platelet count of 88,000.
Mm-hmm.
And
so you think that it's a chronic anemia or acute anemia?
So chronic anemia can be, I think, as she was a vegetarian from prolonged period of time.
So you suspect. Why? No symptoms. Symptoms, if the patient comes with severe anemia with less symptoms, then it is a progressive chronic anemia. They are adapted to that. But whereas in acute anemia, patient will be severely symptomatic. So this patient is well preserved, but she is having edema. So it looks like a chronic anemia, whatever may be the reason. We don't know what is the reason. Okay.
So we went ahead with our anemia investigations. So during that investigation, we found out that her vitamin B12 level was 75.53. It was way below the normal range, which was 187 to 800.
It was 75.
75.
Okay.
Then other than that, we sent the LDH values also. LDH was 4,294.
That indicates what? High LDL values. LDH values.
Hemolysis.
One is hemolysis. Second one.
Liver
obstructive. Somebody is having anemia with a high LDH. One is definitely it is hemolysis. Second thing, you have to strongly suspect lymphomas. Yeah. Many lymphomas you can see LDH will be very high elevated with anemia. Okay, young lady coming with high LDH anemia. Mostly it is hemolysis only, but the high value is very high for a hemolytic anemia. you have to always suspect lymphomas or hematological malignancies. Okay.
And other than that, her TSH was 3.28. Then total iron binding capacity of 200. Then ferritin level was also within the normal level. Iron was 215. So we also send the other routine investigations, and also reti count was also sent. Reti count was 3.75.
Normal or abnormal?
It was above the normal range.
Okay.
Then ESR value was 111.
Okay. So what do you think that ESR is very high? Here, will you give any importance for ESR?
ESR inflammatory
ESR is a marker of inflammation, but what happens to ESR in severe anemia? One of the cause for ESR is anemia itself. Okay. So if you are correcting and ESR coming down, then it is anemia induced ESR elevation. If we even after correcting the blood, then ESR is very high, means there is a strong inflammation going on somewhere, whether it is bone marrow, lymph nodes, spleen, we don't know. Here reticulocyte count is slightly on the higher side. That indicates bone marrow is still active, but it is peripherally destructed. It can be due to various reasons, including your B12 deficiency. B12 is low here. Okay.
So at that point of time, we provisionally diagnosed her with vitamin B12 deficiency anemia, and was started her on vitamin B12
vitamin B12 deficiency anemia, when you are suspecting, there are two important reasons for vitamin B12 deficiency anemia. One is diet. She is a vegetarian. That may be the reason. Second one,
pernicious and
immune mediated immune mediated destruction of your what cell? Parietal cells. Okay. So whatever it may be, the treatment is only one, that is B12 injections, not tablets. Okay. So if you are giving tablets, it will take longer time. If it is pernicious anemia, it will not be absorbed. So better to give IV B12. Okay, that is a treatment of choice.
Along with the vitamin B12, we have started on her on folic acid and riboflavin also.
Okay.
And
so what should be the dose of vitamin B? So that is a secondary issue. When the patient comes with less than 2, what immediate steps you have to do?
Immediate step is to transfuse the patient.
So how do you transfuse a patient who is having chronic anemia?
We can.
How do you transfuse? Suppose you have a patient who is having blood loss anemia, acute blood loss anemia coming to emergency room, like trauma. Another patient coming like this chronic anemia due to, there also anemia is there. What is the main difference between these two? Trauma induced blood loss. Here hemolysis induced chronic anemia. What is the basic difference?
Trauma, first thing we have to stop wherever the bleeding is happening, and
that is
we
important.
have to aggressively correct the blood loss. Because the patient may not be able to tolerate high loss.
So how do you correct that in trauma? How do you correct that in chronic anemia?
In that, actually, we can even give like boluses and even
both you are giving blood only, whether it is bolus or slowly. That is secondary issue. But what is the whether you correct with components or only packed cells? That is the difference. In trauma, what do you do? You are doing now. You are practicing it. Massive blood loss in trauma. How do you manage massive hemolysis and producing chronic anemia? Here, what is the basic difference? Trauma, you are losing blood and plasma and platelet. All three are lost. Either you treat the patient with either you treat with fresh blood. Fresh blood contains all these things.
You can give whole blood,
or you give
all
three components separately. 1:1 combination. That is you call it as sometimes massive transfusion protocol. But here the patient is having chronic hemolysis. Only hemoglobin is low. Their plasma may be normal. The bleeding coagulation proteins may be normal. Platelets are normal, but fluid overloaded. Other condition, patient is fluid depleted. So no need to worry about his fluid overloaded condition. Here, patient is already having compensated fluid overload. So how do you treat?
We give only PRBs.
You give packed cells with Lasix. Okay, so in this type of patients, you have to pre-treat patient with Lasix. Otherwise, definitely they go to cardiac failure when you are transfusing. Okay.
So we started initially with the 20 Lasix IV was given, then followed by transfuser with 3 pints of PRBC at with a great interval between the each
Okay,
pint.
so here also slow transfusion is better than fast transfusion. Other condition you have to transfuse fast. Okay, here you slowly in a day you may be giving only 1 pint. Okay, you cannot give 3-4 pints in a day. Patient definitely will go to cardiac failure. Okay.
So by 2 days we completely give 3 pints of PRBC.
Okay, so you have started PRBC to correct the existing anemia, and you have to correct the B12 also. How do you correct B12?
So injection vitamin B12 can be given 1000 mg per day into 7 days. Will help with the vitamin
Folic acid.
B12
and folic acid has to be given. Both deficiency normally coexist together.
Then we have also sent for the direct comb test and indirect comb test. Comb test came to be 1+.
That means positive.
Positive.
So what do you think? Here you have a patient who is having B12 deficiency, hemolytic anemia, LDH is very high, Coombs test is also positive. So what is your impression from that?
Some component which will be
Coombs test positive means what?
This antibody.
Immune mediated hemolysis.
Is happening.
She already have one problem, that is B12 deficiency, that produces either bone marrow suppression or megaloblastic anemia that induces hemolytic anemia. Another problem is she also got Coombs test positive, that hemolysis is also there, that is due to immune mediated. So two important problems are there. Okay, so Coombs test is positive. Then what you do? Once Coombs test is positive, what you do? It is immune mediated hemolysis.
we had to find out
Is the platelet is low now?
platelet was low.
What is the
Platelet was initial platelet count was 88,000.
Now?
Now and for on the progressive days we reviewed her platelet counts and total counts. Total counts were go in a reducing manner, means the 2.03 became 1 during the days of 3 to 4 days, where the platelet count reduced from 88 to 70, 40, then 20,
So you
20,000.
have all the three cell lineages are
Reducing.
If you have hemolytic anemia due to immune mediated, like this Coombs test is positive, then if the platelets are low in that condition, what do you call it as? What is that syndrome called as? Evans syndrome. So second problem is it can be immune mediated destruction of platelet. Evans syndrome can be there, but this patient also got neutropenia. So third cell lineage also reduced. So now it will become pancytopenia. But only problem here is the retic count is normal. Before giving B12 itself, retic count is normal. That means he is producing cells from the marrow, but it is destructed outside. So it is not only because of bone marrow problem, some other issues are there. Okay, but neutropenia is also there. Okay, so what else you have done?
We have sent for peripheral blood smear also.
And some more problems are there. He has got hair loss.
Hair loss also.
Okay, hair loss is there. Young lady with pancytopenia. What are the differential diagnoses?
Autoimmune is one differential diagnosis.
Autoimmune what? At this age? Huh?
Hypothyroid.
Hyperthyroidism.
Hypothyroid. Hair loss.
Hair loss with pancytopenia. What is the most important differential diagnosis in a young lady?
Apla.
We should have hair loss. SLE. SLE is the most important differential diagnosis. Sometimes it may not be SLE because B12 deficiency itself can produce all this hair loss, blackening of skin, everything. So, but here Coombs test is positive. That is another clue for another clue for another immune mediated disease. Okay. So SLE we have to strongly suspect in this lady. What investigation you do for that?
We will send for ANA and DSDNA.
ANA and DSDNA. ANA may or may not be positive, but mostly it will be positive in SLE and the titers will be very high. DSDNA, if it is positive, you have to confirm that this is mostly SLE. Okay, since she is a young lady, hair loss is there, hemolytic anemia is there, thrombocytopenia is there, neutrophil counts are low. strongly suspect SLE only. Okay. Now what happened then?
Then we sent for the peripheral bed smear also. Peripheral bed smear was showing like pancytopenic picture, and other than that, not significant megaloblasts were seen on the peripheral smear.
Okay.
Initially, we were suspecting of a leukemia picture bar any auto at that point of time autoimmune SLE was a differential diagnosis. So
But leukemia, you don't get megaloblast.
no blast was seen. Not
Blasts
not
are seen, but not megaloblast. Megaloblast is typically a feature of B12 deficiency or something like that. Maturation is arrested. Okay.
So we did the bone marrow biopsy was done. Bone marrow biopsy was showing hypercellular bone marrow with
So bone marrow is overproducing the cells. That means bone marrow does not have any problem. It's all destruction in the peripheries. It can be immune-mediated destruction of platelet, immune-mediated destruction of RBC, immune-mediated destruction of WBC. Okay.
and with the normoblastic to megaloblastic maturation was there. So initially we were with the differential diagnosis of SLE or leukemia. As the aspiration cytology came out negative for the bone marrow, then the most probable chance was for SLE. So at that point of time, we didn't get the ANA reports and dsDNA reports. So a patient was
Clinically to tell SLE, patient should have skin disorder. It's a lupus erythematosus disease. That means redness of the skin, especially on the face, has to be there. There are some conditions where SLE can be subclinical. Subclinical means the actual clinical feature is not there. Actual clinical feature of SLE is skin disorder. That is not there. Other features can be there, like the patient can have immune-mediated hemolysis or seizures, cardiac failure, liver failure, all these things can be there. That also comes under SLE, but actual SLE means skin disorder has to be there. If skin disorder is not there, sometimes they call it as subclinical SLE, but it is not actually, strictly it is not subclinical, it is clinical only, but that typical feature is not there, so you can call it as atypical also. Okay.
So we have the differential diagnosis and more towards autoimmune nature. So we started here initially on steroids, and initial steroids were started, and during that time she went into seizure episodes.
So steroid, what is the dose in catastrophic SLE like this? This is called as catastrophic SLE, like patient coming with cardiac failure, seizure, altered behavior, all these things comes under catastrophic. This patient had seizure also. Okay. So seizure is a classical feature of SLE. Okay. CNS involvement of SLE. It can be due to vasculitis also, CNS vasculitis also. So it can be a part of SLE also. Okay.
So in catastrophic SLE, we have to pulse dose the steroid 1 gram.
Either you can give methylprednisolone 1 gram into 3 days. Okay. Then 1 mg per kg body weight steroid, oral steroid can be started. The patient is poor, you can go for dexamethasone. Dexamethasone is around 40 to 50 milligram. IV is equivalent to 1 gram of your methylprednisolone. Both can be given. Okay. Both are having equal efficacy. Only thing is methylprednisolone can have a better action than dexamethasone in CNS, but in clinical practice both are having similar efficacy.
So we started her on the first dose of steroid. At that point of time, she developed the seizure, and during that time, her platelet count was on the lower range, 20,000. So we were on the suspicion that is there any chance of intracranial bleed is a possibility. So we sent her for a CT brain plane. CT brain plane was showing bilateral frontal region edematous like hypodensities. And for confirmation, we sent her on MRI brain with MR angiogram, and MRI brain with MR angiogram was showing features suggestive.
MR angiogram was MR venogram is actually
MRI and MRV both.
MRV is done to rule out CVT. Cortical vein thrombosis, because SLE, one of the reason for seizure is cortical vein thrombosis. So altered behavior, seizure. Other than your simple bleed is commonest thing, like somebody is having low platelet bleed in the brain is the commonest thing. But in a patient who is having SLE, developing seizure, we had always ruled out, young lady, we had always ruled out CVT.
CVT.
Okay. That's why venogram was done.
MRI and MRV was done and was showing features suggestive of posterior reversible encephalopathy syndrome and with a differential diagnosis of meningoencephalitis.
Okay.
And on looking, there was some vascular changes also noted, and maybe suggestive of vasculitis also. Vasculitis like picture was seen on the MRI.
Yeah, SLE, the problem in brain is vasculitis. Okay. If SLE is not there, it can be sometimes primary CNS vasculitis. Here the problem is SLE that produces vasculitis. That changes can be there in the brain also. Okay.
And she was started on steroids, and for following the seizure episode, she developed breathlessness.
Okay.
And
very rarely even steroids also can produce seizure. That also you should keep in mind. Okay.
And, so breathlessness. Initially we put her on nasal prongs, and she was not maintaining on nasal prongs. Then face mask was tried. It was also not maintaining. So we kept her on NIV, and X-ray was taken. X-ray was showing features suggestive of pulmonary edema.
Okay.
And
so what are the differential diagnosis for such condition in emergency room? Somebody who is having a suspected SLE, developing seizure. Suddenly she develops pulmonary edema. What are the reasons?
So one can be because of the blood transfusion. Initially,
you are given blood transfusion 48 hours. It can be trally.
Okay. This what occurred after 48 hours. Very less likely to be trally.
Okay.
Then the other thing can be pulmonary edema itself.
It can be fluid overload.
Fluid overload.
TACO.
TACO.
Okay.
Then
what is TACO?
Cardiac overload.
Okay, so it's a volume overload. Here it is a different. It's both are pulmonary edema. One is cardiogenic pulmonary edema. Other one is non-cardiogenic edema. But both are possible.
So if as the patient had been transfused, and also is there SLE was in mind, we had to look for the cardiac status also. We did an echo.
No, that is okay. Cardiac failure is another. What is the third reason for pulmonary edema?
Neurogenic.
Somebody is having severe seizures, raised ICP. If they develop pulmonary edema acutely, you have to always think about neurogenic pulmonary edema. Okay.
So
and cardiac failure, SLE patient can have cardiac failure, and steroid you are giving, that itself will produce volume overload. Okay. You are giving some amount of volume through as a steroid, and steroid produces water retention. Okay, so that itself can produce cardiac failure. All these things are possibility.
So cardiac status was also fine. So that
whatever may be the reason for pulmonary edema, treatment is only NIV.
Okay. And Lasix was also started.
Okay.
And so at that point of time, the most probable diagnosis will be neurogenic pulmonary edema. And we kept her on NIV and Lasix infusion. During the next day, we got the reports for the ANA, which came out to be 2+. ANA 2+ was there. Okay,
that means high titer of anti-nuclear antibody. Mostly, possibly towards SLE only. We didn't get dsDNA levels. Okay.
And that day also, she again threw in seizures.
Okay.
She threw in like more than
seizure other than your steroid and other drugs. What else you should start in seizure?
Seizures. If the patient is on active seizure, you had to give benzodiazepines to control the seizures, followed by anti-epileptic medications like.
Which will be ideal drug in this type of condition?
Levetiracetam.
Why you start levetiracetam? What is the reason? In a suspected case of SLE, multi-organ dysfunction. Why did you select levetiracetam?
Very less adverse reaction.
Liver, you are suspecting a liver injury. Anticipating a liver injury. So we have to start levetiracetam. Okay. We can start phenobarbital. Here at present there is no liver injury, but definitely this patient is going to develop multi-organ dysfunction. So better to avoid drugs can produce liver injury.
With the starting of levetiracetam also, she again threw in seizures, and we started her on again lacosamide was also given.
Okay.
And with the lacosamide, her seizures came down, and right now her seizures has been normal. No seizures from that point of time. EEG was done. EEG was normal.
Okay.
And repeat again we for further follow-up we did a repeat MRI also. Repeat MRI was showing frontoparieto-temporal occipital region edema was there. Mostly press like, and her BP was initially like arterial line and central line was put, and the BP was like 200 to 100 mmHg, and initial bolus doses of labetalol was given, and followed by we have started on her hydralazine to control her BP. Right now her BP is like hovering around 150 over 80 mmHg. No new seizures has been started.
Normally they have autonomic dysfunction. These type of patients can have autonomic dysfunction. Better tablet will be labetalol. Better treatment option will be labetalol. Whether you give IV or oral, labetalol is the ideal choice.
And as the ANA was 2+, we started her on rituximab also. Rituximab is right now going on, and
so rituximab also is like steroid, pulse dose of steroids. Okay, only thing is it has got lesser side effect comparing with the steroid. There is no added benefit, like there is no big benefit comparing to the cost of the steroid and rituximab, but definitely there is added benefit. Okay, benefit in the sense of long-term patient like steroid can produce lot of adverse effects. That is not there, but immediately it all same. Okay.
yeah, at present patient has not showing any more seizures, and patient clinically is improving. We are watching for any new developments as at present.
Okay, can we give mannitol for this patient?
So she was having a brain edema. We started her on mannitol also. Mannitol is given initially 100 mg was given, and now TAD Q6 doses of mannitol is being going on.
Okay, what is the LP report?
LP was done. LP was not showing any infective parameters.
Only thing is we have to rule out infection in this type of cases, because vasculitis in brain, sometimes you can get CSF blood RBCs. Otherwise, normally we will not get any change. Sometimes proteins can be very much elevated, but cells will not be there. Here also there is no cells. Infection is not there, so there are no cells. So infection should be ruled out. Okay, what happened to the patient at present?
At present, patient.
What all things you watch in this patient? What all complication this patient can develop in your ICU?
So the patient can go on into continuous seizures.
One is the patient can develop continuous seizures. Anyway, he is on anti-epileptic medication. Okay, then second thing.
Then second, patient can go into respiratory depression.
Why?
Neurogenic pulmonary edema. And
it is over now.
Let him on to the hemodynamics, because acute fluctuation can happen.
So hypotension can occur any time because autonomic dysfunction is there. Then third.
Any acute aortic sensorium can indicate an increase in cerebral edema.
Okay, cerebral edema can develop and patient can deteriorate. Then pulmonary embolism is the next important thing, because this patient is having suspected as prothrombotic stage. Patient is having hypoalbuminemia or whatever it is. Patient is bedridden. So you have to give heparin or domoleculated heparin to prevent DVT and pulmonary embolism. Okay, then eyes. What do you look at eyes in this type of patients?
Eyes, we have to look for any features of hypertension, like
not hypertension. Hypertension are simple things. Uveitis, or other like redness of the eyes, painful eyes. All these things can occur because uveitis and other type of eye inflammations are very common in SLE. Oral cavity,
oral ulcers can be.
Oral ulcers are very important. Where will you get oral ulcers in SLE? Upper, you have to see the palate, not like normal oral ulcers, aphthous ulcers get on the tongue and this one. It will be mostly on the upper part of the palate. Okay. And hair loss is, that's not a big complication in ICU, but patient loses hair. Okay. Then
multiple system can be involved, cardiac,
multi-system involvement.
Okay. Renal, liver.
Then if this patient develops infection in your ICU, how do you treat? Next thing is what is going to come is patient can develop hospital acquired infection, because you are giving high dose of steroids, rituximab, all these things you are giving. So how do you monitor that?
So you have to have reverse isolation.
So then now it is very important that patient should not be kept with
Other patients.
other patient means other infective patients. Okay, they should be very careful. We have to put the patient in reverse isolation. All healthcare staffs, they should use protective goggles or gloves, whatever it is. So all these things we should take care. Like otherwise, patient can develop infections, including fungal infection. Okay. So normally these type of patients we have to give preventive antifungals, PCP prophylaxis. All should be given because lifelong this patient will be on steroids or steroid sparing agents. Okay. What are the other steroid sparing agents you can start for this patient other than rituximab? Rituximab, first 3-4 days they give, then every week we can give, then afterwards monthly you can give, but in between you have to cover with other type of steroid sparing agents.
MMF.
Mycophenolate mofetil, azathioprine,
Azathioprine.
like that. There are a lot of drugs. They also have side effects. Okay, if you start azathioprine, you have to see the LFT, creatinine. MMF is relatively a safe drug. Okay. Anything else? Okay. Thank you.